I think the bulk of what most people are here for today is to talk about the level of evidence and clinical utility of marijuana use for a number of our conditions. When I do look at the American Society of Cancer and Oncology, their 2017 anti-emetic guidelines, their quote directly from the guidelines is that evidence remains insufficient to recommend marijuana for prevention or treatment of nausea and vomiting. Looking at all the evidence that I've presented so far and evidence that I haven't presented on this slide, I've kind of determined that evidence of benefit for anti-emetic effect is fairly low. We do know, at least somewhat anecdotally, that when patients do smoke, they get, the munchies, right? So we do have an appetite increase here. The question is always, is that a clinically significant increase in appetite? Does that provide clinically significant weight gain? It doesn't appear to, based on the evidence that's out there currently. Evidence of benefit for glaucoma is extremely low, and most optometric or ophthalmologists don't actually recommend marijuana use for glaucoma. If you're considering, quality of life for these patients, it's not completely erasing seizures. That's the challenge that we have, but my patients aren't having as many, which means they may be able to leave the house. And so clinical benefit may potentially be there. In nearly every study that you look at for marijuana, cannabis, CBD, THC, any of those for pain, we do show benefit. And so I do have the evidence of benefit marked high here for pain management or analgesia. Cortisol, that stress hormone, you can see has those arrows back providing negative feedback. So as that cortisol is released, that kind of starts to down-regulate that process a little bit. You'll also notice that CB1 receptors do exactly the same thing. And so if I were to utilize marijuana that's going to affect that CB1, that's also going to drop the release of catecholamines. It's going to decrease the release of norepinephrine, so my patients aren't going to feel as anxious. It seems that if your patients are using this as needed, you've had a long day, you come home, toke up a little bit, right? That might help with some of your anxiety, but if it becomes an everyday chronic use thing, it can actually worsen your anxiety. I've kind of placed it as moderate, that some of our smaller studies, certainly if your patient has pain associated with Crohn's, we know that pain is one of our best disease states to be managed by marijuana if we're going to utilize that. Again, probably after other treatments have failed. Nausea might have some benefit here too, but if it's not modifying the disease, I'm basically putting a Band-Aid over a wound, right? And so to recommend as a first-line treatment, I as a practitioner would not, but patients do say they feel a little bit better when utilizing this product. Really anything that's not pain and not spasticity doesn't have evidence, right? But they did confirm most of what we saw up top, where if it is pain or spasticity, there is potentially benefit from marijuana use in that component. So that's how I have my marijuana evidence broken down. Pain, spasticity, very high. Anything else you're targeting multiple sclerosis, very low.